There have been a number of new agents that have been approved for BCG-unresponsive non-muscle invasive bladder cancer in the last couple of years, but there still remains an unmet need for us to bring to patients new regimens that both demonstrate safety and high complete response rates. And the rationale behind the combination that we studied of Durvalumab plus Intravesical Gemcitabine and Docetaxel lies in the fact that both of these agents separately have demonstrated complete response rates as individual regimens. So both Durvalumab and other PD-1, PD-L1 inhibitors have shown complete responses, and the Gemcitabine Docetaxel doublet intravesical therapy has demonstrated complete responses. So we wanted to put them together to see if we could push that complete response rate higher in a safe manner. If we look back with checkpoint inhibitors alone, I think our experiences so far have been with pembrolizumab and atezolizumab from prior Keynote and Southwest Oncology Group trials. And in general, we saw complete response rates in those settings in about the 40%, 35-40% range. Gemcitabine and Docetaxel, it's interesting, we've not really had a prospective trial to define what that complete response rate is in this population. Retrospective studies have demonstrated a 2-year recurrence-free survival from high-grade recurrences of about 50%. We know from clinical practice that Gemcitabine Docetaxel is probably the most active chemotherapy doublet, but we didn't know what that rate was. So the response rates that we've seen of 89% in our all-comers population, it's pretty high. We're encouraged by that. But there are some limitations of our study in that it's a single-arm study. So we're not able to really parse out how much additional sort of benefit from the CR rate does the addition of the Durvalumab add to Gemdosi. But you're right, we're quite encouraged by that. It's one of the highest numbers we've seen so far, but caveat is it's a small study. I would say not terribly surprised. The reason we put that in there was largely because the regulatory path for approvals in the BCG-unresponsive non-muscle invasive bladder cancer population, the FDA has been pretty clear that that's driven by complete response rate in the CIS population. So we wanted to design our trial to make sure that we enrolled enough patients with CIS so that we could at least get a preliminary look at that population. With this complete response rate of 89% in all comers, we knew that was going to be high, probably in the subsets, but it was important for us to parse that out and show that. We actually showed that we saw three of our recurrences were muscle invasive out of the 37 that were evaluable. If you look at most BCG unresponsive non-muscle invasive bladder cancer trials that have been done, we do see progression to muscle invasion in those patients. It's usually somewhere in the 4 to 8% range. Again, our trial's small, so if we had one less progress or one more, those numbers could be a little bit larger than others. I think an important point when we look at that is to really parse out the patients that come into the trials. In our patient population, we did have a heavily pretreated population. Our patients with CIS, most of them had concurrent papillary, including high-grade T1 disease as well. So we had a fairly high risk even for BCG unresponsive population that came in. But that's something that we need to watch for in these studies. I think our rate of muscle invasion is consistent with what we've seen in other trials. But I think another thing that may help us in the future will be better biomarkers, potentially some of the ctDNA, urine tumor DNA, and other prognostic signatures on the genomic side may help us. Yeah, I think your first point is very accurate, that we need longer follow-up. And I think what we're seeing in the BCG unresponsive patient population in clinical trials is that we've now seen several trials, ours now adding to that have demonstrated high complete response rates. And so our prior approach to making a decision about is a regimen encouraging or not based on response alone, we're probably going to need to wait a little longer in some of these studies, because trying to look from one trial to another at a complete response rate of, say, 60% compared to 70%, they're all in the same range. So it's going to be the durability, 12 months, 24 months, how many of those patients, stay in a complete response. I don't know that we can say they're cured. We're going to need long-term follow-up for that. But I think that will distinguish some of the regimens from each other. Some of the regimens we've seen with longer follow-up, those complete response rates start to drop off. And our trial is just much too immature. We have, as mentioned in the swimmer's plot that we showed, there are some patients that at the data lock had their first disease evaluation that are only 3 months into treatment. So we're going to need a little more time, and we do anticipate bringing that data out once it's a little more mature.